Hi, this is Dr. Bridget Holleran. Today, we will be discussing drugs that affect the thyroid. We will take a few minutes to briefly review the pathophysiology of the thyroid gland. The thyroid gland produces hormones that have a profound effect on metabolism, cardiac function, and growth and development. These hormones stimulate the metabolic rate of most cells, and they increase the force and rate of cardiac contraction. During infancy and childhood, thyroid hormones promote maturation. A severe deficiency of thyroid hormone can produce extremely short stature and permanent mental impairment. Fortunately, most thyroid abnormalities are treatable. Before we talk about disorders and treatment options, we are going to review what we know about the thyroid's normal feedback system, called the HPT axis. The functional relationship between the hypothalamus, anterior pituitary, and thyroid is shown here. When you hear the word euthyroid, it means the thyroid gland and the feedback system are functioning normally. At the bottom of this slide, you will see 4 hormones listed. The TSH, or thyroid stimulating hormone, is the one you will hear about most often. This is the main hormone that regulates the thyroid gland. The TSH is the one that we will monitor with serum lab work to screen for thyroid disorders or check for effectiveness of treatment. Reference ranges may vary slightly, but for this course, we will use 0.5 to 5. Of the 4 hormones listed on this slide, the TSH is the only value I want you to memorize. In addition to TSH, the HPT axis also includes T4, or thyroxine, T3, or triiodothyronine, and TRH, thyrotropin-releasing hormone. When you think about problems with the thyroid, remember that both the hypothalamus and anterior pituitary gland are involved. And a normal thyroid gland will have to make adjustments in the amount of hormone produced in response to positive or negative external stimuli. As long as there's an adequate amount of thyroid hormone, T3 and T4, circulating, the thyroid gland is on autopilot. However, when there are low levels of circulating thyroid hormones, again, we're talking about the T3 and T4, the hypothalamus recognizes this and responds by making TRH. Well, what does that do? Well, the increased production of TRH alerts the anterior pituitary gland to release more TSH, thyroid stimulating hormone. That increase in TSH basically begins yelling at the thyroid gland to wake up, produce some more thyroid hormone. The thyroid gland responds and secretes more T3 and T4 into the bloodstream. Does that make sense? So again, as long as there are adequate amounts of thyroid hormone in circulation, the thyroid doesn't need to make more. This is an example of a negative feedback loop. Again, the system will stay on autopilot until the circulating levels rise or fall out of the normal range. So you can see why those levels will have an inverse relationship. The TSH is high when the T3 and T4 levels are low. Another way to think about the negative feedback system is to think about the heating system in your house. In the winter, I keep my thermostat set to about 74 degrees. As long as the temperature in the room is consistent, the furnace is on standby. But if the temperature drops below 74 degrees, the thermostat recognizes this, and the furnace will automatically turn on in an attempt to warm the room back up to the desired temperature, 74 degrees. Once the temperature is back in range, the system shuts off and is on standby again. The pituitary gland is like the thermostat, and your thyroid gland is like your furnace. The thyroid hormones are like heat. So, what did we say in the beginning about which circulating hormone we usually measure to see if our system is working properly? Right, the TSH. Serum TSH, not T3, not T4, is used for screening and diagnosis of thyroid disorders. The TSH is also the lab test we order to determine the effectiveness of treatment if we are replacing thyroid hormone in our patients with hypothyroidism. Okay, stop taking notes for just a second. Look at this picture again and think about this. Again, I'll put my cursor here, kind of in the middle. If we have hypothyroidism, let's think about hypothyroidism. We have a low functioning thyroid, not producing enough T3 or T4. Goes back up the chain, right? And what do we expect that TSH level to be? Will it be low or high? Yes, the TSH will be high. Why? If the thyroid hormones that are being produced are inadequate, meaning they're low, then the hypothalamus and the anterior pituitary gland will be alerted and sound the alarm, right? They're going to be putting out that distress signal to the thyroid to wake up. You got work to do. You need to make more thyroid hormone. So the amount of TSH will be high. Does that make sense? If not, go back to your text and do some additional reading to be sure you understand. Your textbook has a nice review of thyroid disorders and the common signs and symptoms you will see with each. I have added a quick overview of common findings here. Remember, with hyperthyroidism, or an overactive thyroid, metabolism and cardiac function are revved up. And with hypothyroidism, a low-functioning thyroid, metabolism and cardiac function are slowed down. On the left side of this chart in red, we see a list of the signs and symptoms you often see with an overactive thyroid, including unintentional weight loss, increased appetite, heat intolerance, tachycardia, palpitations, diarrhea, anxiety, irritability, insomnia, tremors, and increased sweating. The signs and symptoms on the right side in blue are associated with a low-functioning thyroid and include the opposite in most cases. Stop the recording and take a few minutes to review the whole list if you need to. If you are familiar with the children's classic Winnie the Pooh, think about the character Tigger as a representation of hyperthyroidism and Eeyore as a representation of hypothyroidism. The specific medications we use will depend on the type of thyroid disorder we are treating, hypo or hyper. For the remainder of this lecture, we will be talking about thyroid hormones that are used to treat hypothyroidism and antithyroid agents that are used to treat hyperthyroidism. So let's talk about the treatment for hypothyroidism or underactive thyroid. Again, think about Eeyore. This is another image that shows us that negative feedback loop that we discussed a few slides ago. If we have a low or insufficient level of circulating T3 and T4, the hypothalamus and pituitary glands recognize this and start sending out those messages that will ultimately increase the production of TSH. The increased TSH will signal the thyroid to make more T3 and T4. So we have that high TSH level. So, in the treatment of hypothyroidism, we need to supply the thyroid hormone because the feedback system's not working properly. There are two types of agents. There are natural and synthetic preparations of thyroid hormone. There are many forms of hypothyroidism, and it can be seen in all age groups. Your textbook has a nice review of those if you need them. In the United States, the most common cause of hypothyroidism in adults is Hashimoto thyroiditis, which is an autoimmune disorder. Worldwide, hypothyroidism is most often a result of iodine deficiency. We also see hypothyroidism after radioactive therapy or surgical treatment for hyperthyroidism or thyroid cancer. Since there's not enough thyroid hormone, we're going to have to replace it. Natural thyroid preparations are not approved by the FDA for the treatment of hypothyroidism. So why are we mentioning this? Because you will get questions about this from patients. Many patients assume because these are available at health food stores, they're safe, which is not true. They are primarily derived from beef and pork thyroid glands. In some cases, they might actually be cheaper. However, they do not contain consistent amounts of thyroid hormones, and the bioavailability can vary from dose to dose, even in the same product. Why is this a problem? Because not only will patients have unreliable control of their symptoms, fluctuations of thyroid hormone are more likely to cause dangerous cardiac symptoms. Patients should be educated that these products are not interchangeable with prescription synthetic medications. Synthetic preparations of thyroid hormone are more stable and better standardized. Therefore, they are preferred to natural products. Levothyroxine is the prototype drug and the recommended first-line treatment for all forms of hypothyroidism. Its structure is identical to thyroxine, which is T4. For adults, the starting dose is calculated based on ideal body weight, not actual body weight, but ideal body weight at 1.6 micrograms per kilogram per day. For adults, typical dosages may vary widely, anywhere from 50 to over 200 micrograms a day. Treatment for babies or children with hypothyroidism will be based on age, not weight. Newborns with congenital hypothyroidism and pediatric patients will be managed and followed by a pediatric endocrinologist. Older adults should be started at lower doses, 12.5 to 25 micrograms a day, and titrated up slowly. Now, remember we said that thyroid hormone deficiency in children can cause growth retardation and permanent mental impairment, right? So, we do want to continue levothyroxine during pregnancy to ensure proper fetal development. The levothyroxine dose will usually need to be increased during pregnancy, sometimes by 50%. Most often, the OBGYN will be managing this, but you will get questions from your patients who might be considering pregnancy and want to know what to expect regarding their regular medications. We need to be cautious when starting levothyroxine in patients with known cardiac problems. They should be started at low doses, 12.5 to 50 micrograms a day, and you may even consider waiting longer than 6 weeks to recheck the TSH level. Remember, we said that more thyroid hormone will increase cardiac function. Thyroid meds provide more thyroid hormones, so this can also increase cardiac function. Therefore, we need to educate patients on the potential cardiac symptoms that could develop, including increased heart rate, blood pressure, new or worse chest pain, palpitations, or edema. Levothyroxine should not be initiated for patients who have recently suffered an MI, or myocardial infarction. How do we know if we should increase the dose? Increases should be based on both TSH levels and patient response. We will titrate this drug up 12.5 to 25 micrograms a day every 4 to 8 weeks until the TSH is in the normal range. Because of the long half-life, it takes about a month to reach steady state, so do not check your TSH any sooner than 4 weeks. Again, every 6 weeks is a good rule of thumb for repeating TSH levels. There's been a lot of debate over the years about whether or not branded versus generic formulations of levothyroxine are truly equivalent. We're not going to continue that debate here, but you should try to avoid changing manufacturers or formulations when you can. If the product is changed by the pharmacy based on supply or availability, you should recheck the TSH in about 6 weeks and adjust if needed. Again, we know because of that long half-life that it's going to take that long for serum TSH to reflect the dose adjustment. Teach patients to take their levothyroxine on an empty stomach, first thing in the morning, about 30 to 60 minutes before eating. When administered at appropriate dosages, levothyroxine rarely causes adverse effects. If a patient has taken too much of their levothyroxine, you might see signs and symptoms similar to thyrotoxicosis. Thyrotoxicosis is when we have overactive thyroid. We can see profound tachycardia, angina, tremors, anxiety, difficulty sleeping, hyperthermia, heat intolerance, and sweating. We will talk more about hyperthyroidism or thyrotoxicosis in a few minutes. Long-term effects of excessive thyroid hormone include bone loss and/or osteoporosis. Excessive use of thyroid hormone also increases the patient's risk for AFib. For this reason, it is particularly important when prescribing or sending refills to monitor those serum levels and adjust dosages accordingly. Often, patients can be reluctant to decrease their dose of levothyroxine when they're feeling well, even when their levels reflect an excess. Absorption of levothyroxine can be influenced by a variety of medications. There are several medications that reduce the absorption of levothyroxine and should be taken 4 hours apart instead of the normal 30 to 60 minutes. Some of those include iron supplements, calcium, sulcrophate, PPIs, and bile acid sequestrants. There are also drugs that will increase the absorption of levothyroxine. So you might need to increase the dose of levothyroxine if your patient is on phenytoin, carbamazepine, rifampin, sertraline, or phenobarbital. I know we haven't learned about most of those yet, but it's important that you know them. Be mindful in case any of these drugs are added by another provider. When the patient follows up with you and one of these medications have been added, it will be important to remember to recheck that TSH and adjust if needed. Levothyroxine can enhance the effects of warfarin, so the dosage of warfarin may need to be reduced if levothyroxine is added. Levothyroxine can increase the body's requirements for insulin and digoxin, so dosages of those medication may need to be increased if a patient is on levothyroxine. After all we have just discussed, it should make sense that we don't want to manipulate the thyroid gland in order to promote weight loss. At times, we may find that patients are misusing the medication for weight loss. They may not understand the serious potential adverse effects. Emphasize that in a euthyroid state, which means that TSH is in normal range, the dose would be ineffective for weight reduction. And again, emphasize that the consequences of overtreatment are dangerous. Unfortunately, I still see this used quite often in practice as a treatment for obesity. Tell your patients it is not recommended, safe, or effective. In summary, when monitoring for effectiveness, we should see the signs and symptoms of hypothyroidism resolve when the patient returns to a euthyroid or normal state. Of course, we are also looking at the TSH level about 6 weeks after initiating treatment or changing the dose. Both are important factors when monitoring for effectiveness. Again, we want to avoid changing products if we can, but if the product is changed by the pharmacy, based on supply or availability, you should recheck the TSH in about 6 weeks and adjust again if needed. In children, resolution of signs and symptoms may include normalization of intellectual function and growth and development patterns. Again, pediatric patients will be managed by endocrinology. Once we are satisfied that the patient has achieved a euthyroid state, you can monitor the TSH yearly. Now pause the video and calculate the starting dose of levothyroxine for a healthy young adult female who weighs 126 pounds. Did you come up with 88 micrograms daily? Good! So let's walk through this together. The client's weight must first be converted from kilograms to pounds. 126 pounds divided by 2.2 is 57.2 kilograms. The recommended dose is 1.6 milligrams per kilogram, so we multiply 1.6 times 57.2 to get 91.5 micrograms. Now what? Well, what are our dosing options? Look at your drug reference. I like to use the free version of Hippocrates. If you look under the adult indications and dosing, it tells you that the starting dose is 1.6 micrograms per kilogram per dose and how to adjust. But where do we find our dosage options? The easiest way is click on the Calculate Dose in blue, and now you see the same description for indication and dosing information, but after it, there's a list of the forms that are available. Both capsules and tablets come in multiple doses. Closest to our 91.5, there's an 88 microgram option. So that's what we would prescribe. You can find this same list of options under the Manufacturing or Pricing tab from that home page of the levothyroxine in Hippocrates. You may prefer to use a different drug reference, and that is fine. You should be able to find the same information. Now, bonus question. After we start this patient on levothyroxine, 88 micrograms daily, when do we check the TSH? You got it, 6 weeks. So now let's talk about the treatment of hyperthyroidism, or an overactive thyroid. Again, here's that negative feedback loop that we discussed earlier. This time, if we have high or excessive levels of circulating T3 and T4, the pituitary gland recognizes this and knows to decrease the production of TSH, which will signal the thyroid to make less T3 and T4. So we'll have a low TSH level. Make sense? The TSH is low and the T3 and T4 levels are high in hyperthyroidism. So to treat high levels of TSH, we use anti-thyroid agents. We will talk about thionamides and iodines. Hyperthyroidism, sometimes called thyrotoxicosis, is when we have excessive levels of thyroid hormones. There are two major forms of hyperthyroidism: Graves' disease and toxic multinodular goiter. Graves' disease is more common. Your textbook has a nice review about both of these if you want more. In hyperthyroidism, the goals of treatment are to either 1. Inhibit the synthesis of the hormones, or 2. Destroy the thyroid gland tissue. In the United States, the most common definitive treatment for Graves' disease and toxic multinodular goiter is radioactive therapy using I-131. But you will also see drug therapy used alone or as a pre-treatment before radioactive iodine therapy or before a thyroidectomy. Most of the time, our treatment for hyperthyroidism is initiated and managed by an endocrinology specialist. However, in the primary care setting, you will likely see patients on methimazole or propylthiouracil, PTU for short, if they're on these for long-term therapy. These are classified as thionamides. We also have iodine treatments, both non-radioactive and radioactive. You won't encounter these much in the primary care setting. Using non-radioactive iodine, such as Lugol's solution, is not used as often anymore. We said earlier that iodine plays an important role in the production of thyroid hormones. Remember, I told you that worldwide, iodine deficiency is the #1 cause of hypothyroidism. So it might seem strange that we would use an iodine solution to treat excessive levels of thyroid hormone, doesn't it? Well, at very high concentrations, the iodine has a paradoxical suppressant effect on the thyroid. This won't work for a long period of time, so Lugol's solution is typically used to suppress thyroid function in preparation for a thyroidectomy. Lastly, we have radioactive iodine, or I-131, which will most definitely be used by a specialist in an inpatient setting. For the remainder of this lecture, we will focus our attention on the thionamides. Methimazole and PTU can be used long-term for treatment or for short-term treatment before surgery or administration of radioactive iodine. Remember that although these drugs may prevent the synthesis of thyroid hormones, they don't destroy the existing stores of thyroid hormones. So expect 3 to 12 weeks to produce a euthyroid or normal state. Methimazole or Tapazole is your prototype drug and is still considered first-line therapy for hyperthyroidism. I highlighted the M in green in methimazole to help you remember it's the one we use most of the time. So M for most of the time. One of the most distinct differences is that methimazole can be used in both adults and children. Additionally, the less frequent dosing is more convenient, which improves compliance. I have highlighted the P in PTU and the P in pregnancy to help you remember that this is your drug of choice in early pregnancy. It's also preferred in breastfeeding. We will spend a few minutes discussing each of these drugs individually. We know these block thyroid hormone synthesis. And we said earlier that methimazole is safer and more convenient. When it is started initially, a patient may take it 1 to 3 times a day. But once they're on a maintenance dose, it will be taken only once a day. Since these are not drugs we will be prescribing, I'm not going to ask you to memorize the normal dosages. But I do want you to know that methimazole is given once a day and PTU is given 2 or 3 times a day. What do you think when you see the next bullet point there that says it's not protein bound? Well, if it's smaller and it's not protein bound, will it cross the placenta easier? Yes, it will. Therefore, we do not want to use this drug in early pregnancy. If used in the first trimester of pregnancy, it can cause neonatal hypothyroidism, goiter, and even congenital hypothyroidism. It is considered safe to use later in pregnancy. Because of the shorter half-life, PTU is dosed 2 or 3 times a day. It also has more adverse effects. And as we said a minute ago, we don't use this for children. It is protein bound, which makes it our preferred treatment in the first trimester of pregnancy. Both of these drugs are generally well tolerated. And again, which drug would you expect to have less adverse effects? Yes, methimazole. Potential adverse effects are listed here for you. Thionamides also carry a potential for drug-induced hepatitis, so we will want to monitor liver enzymes. The most dangerous adverse effect, however, is agranulocytosis. This is when you have an extremely low number of granulocytes, which are white blood cells, in the blood. Granulocytes are an important part of the immune system and help the body fight infection. This adverse effect is rare, but you need to know about it. Even if you are not prescribing these medications, you may see a patient that presents for, say, a sore throat who's recently been put on a thionamide. So you need to be aware of the potential for agranulocytosis. Sore throat and fever may be the earliest indications. Agranulocytosis often develops rapidly and would prompt discontinuation of the medication. Now remember, we said that it may be weeks to months before antithyroid agents produce a euthyroid state, right? So, what do we do for our patients who are tachycardic and restless and anxious in the meantime? Well, we often put them on beta blockers. Now, we have not studied beta blockers yet, but all the generics end in OLOL. Propranolol, atenolol. These are drugs that help to decrease the heart rate. They can help with that restlessness, agitation, and anxiety. Be sure that you understand the distinction. Beta blockers do not treat the hyperthyroidism. They only help with the symptoms. Lastly, I want to mention thyrotoxic crisis, often called a thyroid storm. This occurs when we have significantly elevated levels of thyroid hormone. This can occur in response to a major surgery or during severe illness. This is considered an emergency and requires immediate treatment as it can be life-threatening. It is imperative that clinicians recognize this and immediately refer the patient to a higher level of care. Let's practice what we have learned. An older adult with osteoporosis and hepatitis is taking levothyroxine or Synthroid. Which of the following is a potential adverse effect? If you said B, you are correct. Hepatitis is associated with decreased hepatic function, which may slow the metabolism of levothyroxine. In turn, this could lead to a prolonged effect of the medication. Levothyroxine is unlikely to cause falls because it tends to increase, not decrease, the blood pressure, and it does not impair cognition. Decreased bone density is a potential complication of chronic thyroid excess, and thyroid storm is associated with untreated hyperthyroidism, not the effects of taking levothyroxine as prescribed. A newborn is diagnosed with hypothyroidism. What would likely develop if the condition is left untreated? A is correct. If congenital hypothyroidism is untreated during the first several months, permanent intellectual disability is likely to result. What finding would be consistent with a patient receiving too much methimazole or tapazole? Right, A, decreased appetite. Decreased appetite is associated with hypothyroidism, suggesting that the client is receiving too much methimazole, an antithyroid drug. Nervousness, tachycardia, and flushed warm skin would indicate hyperthyroidism, suggesting that the patient is not receiving enough methimazole. Heat intolerance and increased sensitivity to heat are symptoms of hyperthyroidism. Okay, last question. Which of the following is a potential adverse effect of methimazole and PTU? You got it, A again, agranulocytosis. Agranulocytosis is potentially the most serious adverse reaction of the antithyroid drugs methimazole and propylthiouracil. Older adult clients are at increased risk for adverse cardiovascular events when taking thyroid drugs, but a myocardial infarction is not considered an adverse effect of these drugs. If a patient has suffered an MI recently, levothyroxine is contraindicated. Taking levothyroxine in clients with diabetes may increase the risk of hyperglycemia, and causes of pancytopenia might include chemotherapy or medications causing bone marrow suppression. Also, some medications like antibiotics, hypertensive, and other heart medications, but not thionamides. Hope you have learned something today and wish you a great rest of the week. This is the end of our lecture on thyroid disorders.